So for this lesson, we're going to spend a little bit of time now doing an introduction to some of the basic principles that we're going to be looking at during the course of our Step 3 critical appraisal of the relevant evidence. We'll be basically spending some time defining terms and getting a general idea of what sort of things we're looking for in this Step 3. And then in future lessons, we'll dig a little bit deeper into what these means, how we calculate them, and how we can really find out how to use these terms and use these principles to critically appraise our evidence. So objectives for today, basically understand a little bit about reliability and the reasons before it, as well as get into the differences between validity and reliability, introduce prevalence testing, and then specifically talk a little bit about sensitivity, specificity, and how these can be used clinically in more diagnostic type approaches to evaluation of literature. So basically, when we use terms like reliability in analyzing evidence and in research, we're simply talking about consistency of measurements, or consistency within a singular measurement. So basically, are we going to get the same outcome over different periods of time or between different individuals? So there are several different types of reliability, and we'll go through each one of these here momentarily. But when we think about reliability as a whole, it's important that we spend time thinking about why we care about reliability to begin with. The reason that reliability is the first thing we're going to talk about and we're going to focus on is because if we don't have consistency amongst the measures, then we have no ability to ascertain whether or not potential differences are due to errors in measurement or it's due to differences between group. And so if we do not have a reliable study or reliable methods, we cannot make any conclusions. And so we need to spend a lot of time understanding reliability to begin with, because without it, nothing else really matters, because we have so much error associated with the measurements that we can't take anything further. So internal reliability is more of a survey type term. Internal reliability focuses on the consistency within the survey itself. So the idea here is that if a survey is trying to address a specific issue or a specific thought, then the answers concerning that issue or thought should be consistent throughout. So oftentimes in survey research, what the researchers will do in their survey is to have more than one question assess the same concept. And they'll be phrased slightly differently, but basically are asking for the same information. If the survey has a high level of internal reliability, it should be assumed that the individual would answer both questions in a similar way. If they answer one question in one way and another question in the other way, and they're both supposedly asking for the same thing, that's an example of a poor instrument. And so you can see how we wouldn't be able to use any of the findings from that survey, because we don't know whether or not the information that was gathered from the survey is accurate or whether or not it's due to potential errors within the survey. Test-retest reliability is probably the most commonly thought of aspect of reliability, and this is just reliability with repeated trials. Basically, the ability of the measure to get the same result each time you test them. So like in the case of measuring range of motion with a goniometer, the test-retest reliability would be whether or not that goniometer would be able to measure the same amount of motion each time with that individual. Inter-rater reliability now is the reliability between different people using or performing the same procedure or test. And so opposed to other forms of reliability, this has more to do with the procedure opposed to the instrument. Is the procedure set in a way so that more than one individual can test using that procedure, and each tester comes up with the same information? This becomes particularly important if you have more than one tester in the research project. So if you have two different testers evaluating the same thing, but they're doing it slightly differently or coming up with different results, that affects the ability to understand whether or not the differences are between groups or simply between testers. Intra-rater reliability now has to do with the procedure and the reproducibility of the procedure within a singular person. Is the same person able to get the same result multiple times? And so this obviously assumes that the test-retest reliability of the instrument is accurate. So does the instrument get the same result time after time? Is test-retest reliability. If the tester gets the same result time after time, that would be intra-rater reliability. Validity, then, now is the ability of the measure to assess the variable of interest. So basically, what validity is, and for a test to be valid, it has to actually measure what it says it's measuring. So if we say that it's measuring strength, the measure actually has to be able to measure strength, not necessarily, muscular endurance or muscular power, different components like that. So we have to be able to evaluate the method of assessment to make sure that it is actually measuring the construct of interest. So how that occurs is different depending on each measurement. But we're going to basically look at the different types of validity, and what we'll end up doing during our assessment of literature is looking at what type of validity assessment was done on the methods and whether or not that was appropriate for what is occurring. So face validity is the least robust. Basically, the face validity is based off of the knowledge and expertise of the researcher. It's simply that the researcher believes that the instrument measures the intended objective. Now, sometimes this can be appropriate in situations where we have a pretty decent idea of what's going on anyway. And so we don't truly need more robust validity testing. Now, something like a 40-yard dash measuring overall speed is probably fairly appropriate in certain circumstances, especially in sprinters. Right? Whether or not a 40-yard dash measures speed in a football player might be debatable from the standpoint that rarely do football players run 40 yards in a straight line. And so you can see how face validity could be appropriate in certain aspects, but not in others. But short of going through more robust validity testing for every single measure in every single situation, which would basically double the amount of research that would need to be done, because first you would need to do a validity testing of the methods that are appropriate for your patient population. And then run your study. We use face validity basically where we take something that has been shown to be valid in one situation and apply it to a new situation and assume that that validity would carry over. Content validity is a little bit more robust, but not as much. Basically, it goes from a single researcher to a consensus group of experts. And so you can see this most often in surveys, where surveys will end up going to a group of evaluators for the survey, and this group will decide whether or not that survey is accurately measuring what they expect it to measure. This is particularly important for survey research where you're evaluating something relatively new or trying to get perceptions about specific components, where the most important thing is probably that the questions are clear and understandable and reproducible, opposed to whether or not they're can be linked to some sort of other form of valid measure. If we're simply asking about perceptions about a specific thing, really we're focusing on definitions for validity. If we're asking about your perceptions on, say, PowerPoint, so to speak, basically the only real thing we need to do to make sure that the method is valid is make sure that our participants know what PowerPoint is. If people are thinking of, say, Google Slides or something else, then when they're answering that question, then obviously it wouldn't be valid because it's not answering what we're trying to focus on. But if it's clear to a panel of experts that understand the situation and understand the content in its basic frame of reference, then you can assume that there's a decent amount of validity, especially in new survey research. Criterion validity now is going to be more when there is a gold standard or something that we already know is assessing what we want it to assess, and then we can compare our new method to that gold standard. And so there's a couple of different ways to go about that. And there's known group validity, which is basically your ability or a measure of a special test, usually in this case for criterion validity, to differentiate between those with and without the condition. Compare that to predictive validity, which is the ability to assess the potential for future uh, injury or different things of that nature. So it's really the idea of whether or not we can differentiate between those with and without a condition, or whether or not we can predict those individuals that might suffer the condition in the future. And so when we move beyond that as far as validity, one of the biggest components of validity testing that occurs in the literature is that of assessments of new special tests. And so this usually is not as important for our step 3 assessment of research, but it's important to assess what you already have learned regarding diagnostic procedures. And so for lack of a better place, we're going to discuss diagnostics during this lesson, and then delve a little bit deeper into it after we introduce the terms. But if you look at prevalence, prevalence is basically a percentage of correctness. And so we're looking to try to get a situation where we can have as much accuracy as possible. We measure those then and create these outcomes which we refer to as sensitivity and specificity. Sensitivity is the ability of a test to correctly identify the condition, basically the number of people that test positively on the test that also have the condition, whereas specificity is the ability to rule out the presence of a condition, or basically the number of people that have a negative test and also do not have the condition. And so when we're looking at these tests, we make this basic quadrant aspect where we have on the left side with the new test, both positive and negative findings. The test is either positive or negative. And then we have those that have the disease, either positive, meaning they have it, or negative, they do not have it. And so you can see the goal is to have the test be correlated with the disease, where a positive test means that they have the condition, as in box A, which is termed a true positive, or if they don't have the condition, they have a negative test, which is in box D, which is a true negative. And so the definitions basically of true positive and true negatives are: a true positive is when the test correctly identifies the condition, and then a true negative is when the test correctly rules out the condition. You compare that to false positives and false negatives, which would be box B and C in that previous picture. And you see a false positive is when the test says that somebody has the condition, but in real life they do not. And a false negative is then when the test says they do not have the condition, but they really do. And from there, we can take those and calculate the sensitivity and specificity values. And then we continue on to move that towards clinical decision making by creating a new outcome that is called positive predictive value or negative predictive value. And these are basically how much we can rely on positive tests and negative tests for this new special test. Those then go even further into this idea of a likelihood ratio, which basically then starts to create more math that you can then put into a nomogram, which is basically a graph that will allow you to assess pre- and post-test clinical probabilities. And so, although we'll get into this in more depth here shortly, right now the purpose is to understand that sensitivity and specificity are the measures, are the base measures that we use to then decide whether or not clinical tests have a usefulness and how much of a usefulness it makes in getting to our clinical probability, which is what we really want. So there are several steps along the way, but sensitivity and specificity are the first steps towards deciding whether or not individuals have or do not have a condition. So wrapping up, we talked a little bit about the importance of reliability and the need for reliability in order to assess anything of relevance within our clinical decision-making process. We also discussed how validity is more the measure, its ability to actually detect what is occurring and what it says that it's measuring, whereas reliability is the consistency over time. And then we started to introduce the idea of prevalence testing and sensitivity and specificity, but we will get much more in depth into that in the future.